to the point where they can do their job.
They're getting somewhere.
They're just a little ugly.
Right.
Or abnormal looking. But they can still do their job, we think.
Welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Victoria Schulte. Welcome to the show, Victoria.
Hello.
Victoria is a laboratory technician and a specialist in andrology at Missouri Fertility in Columbia, Missouri.
Mm-hmm.
You've been working there for a number of years.
Almost 2 years.
Almost 2 years now.
In August. It's almost 2 years.
Is it an interesting job?
Oh, it's so interesting. It keeps you going.
Never a boring day, I don't think.
Never.
And Victoria has a bachelor's of science in biology from University of Missouri. Mm-hmm. And did you grow up in St. Louis?
Yes, I did.
So
in North County, St. Louis.
And you went to Catholic school system?
Yeah, I did the whole Catholic circuit, did it all. And yeah.
And today we're going to talk about sperm. Sperm are essential for reproduction. I tell all my fertility patients that are trying to have a baby, we have to have 3 things. Got to have good eggs, good sperm, and a good uterus. There's no negotiating or bargaining or any way around the simple fact of biology. And if we have any a problem with any of these things, we're not going to get a successful pregnancy. Now, I have a friend who has asthma, and when he gets an attack, breathing, every breath is special, and he thinks about it.
I also have asthma.
Oh, you have some asthma
Yeah.
too, so you understand.
Yeah.
But for most people, when they're breathing, we don't think about it. It doesn't seem like it's special. So what? I'm breathing, right? Who thinks about it? Well, if you're having trouble breathing, it's a big deal. Infertility is very similar. People who just have babies, they just, sleep together, have babies, they don't think about it. Mm-hmm. But 1 out of 6 couples has trouble conceiving. So things that are otherwise normal and not very thought-provoking for other people are a big deal.
Yeah, you don't think about it until you have to.
And
that's so many things. It happens with everything. So many medical things. So many people don't think about it until like, oh, no, it can't happen to me. And it does.
Right.
So it's random.
So something as intimate as sex, all of a sudden, there's people peering into your personal life, and all of a sudden you got to make sperm on demand sometimes. Mm-hmm. And it sheds a whole new light. It puts a whole new complexion on it, doesn't it?
Yeah, it makes one thing that was once fun now a medical issue.
Yeah.
And it takes all the fun out of it to some degree.
To some degree, yeah. So that's a big deal. That's a big deal. So we have to have good sperm. And it turns out that when we have couples with infertility, on average, up to half of couples have a sperm problem. Mm-hmm. People think it's just the woman, and that's not the case, is it?
No, it's a huge misconception. And I think it's because so many women will discuss it with other women. And a lot of men don't discuss it. Like I've had men come in here and be like, oh, the guys at work made fun of me this morning coming in here. And so many guys are like, oh, I can't tell work what I'm here for. Because then they don't discuss it. So they don't know it's a problem for other men or it could be a problem for them. Because they don't discuss it.
Yeah, so hopefully one of the things that will come out of this discussion will be some openness, and so we'll take some of the embarrassment away.
Yeah, infertility is a male and female issue.
Yeah.
It's not just female.
Not just female at all. So when let's say a normal, healthy, fertile couple is getting pregnant, they have sex, and a guy will very naturally make up to 200 million sperm per sex act. And these sperm have to get up into the woman's fallopian tubes. So we may start out with 200 million sperm, but getting up in the tubes is a long, arduous process. It's a long journey. Mm-hmm. And in fact, only maybe several thousand sperm might make it up into a woman's tubes.
It's survival of the fittest.
Survival of the fittest, and very inefficient. Mm-hmm. Very inefficient. So as I show the pyramid of inefficiency, which applies to many different parts of reproduction. It turns out you need a lot at the bottom to get enough sperm up at the top where we need them to work, right?
Yep.
And it turns out one sperm on its own cannot fertilize an egg. It takes thousands of sperm. And in fact, in the lab where you work, when you're in the IVF lab, if we're doing old-fashioned fertilization, in order to get the best fertilization rates, we need up to 15,000 sperm on top of each egg. So it's a group effort, and we're going to talk about how sperm work together to achieve fertilization. So we need to get sperm on target. In nature, it takes many thousands of sperm to fertilize an egg, but we can also help nature in the IVF lab, can't we?
We can assist it a lot. To
How
where
do
we
we-
can have those 15,000?
Yeah.
We can go from that to one.
To one.
To one with
And-
ICSI.
With ICSI.
Yes.
What is ICSI? Intracytoplasmic
Intracytoplasmic
sperm injection. Or
we pick the best looking one, the brightest looking, best one.
Right.
We pick it and we said, you're going to be the special one. And then our embryologist chooses it specifically, and then he inserts it into the egg.
Directly injects
into
it.
the egg.
And we're going to talk about how we select those good-looking sperm. And you're going to help us with how you pick the shape of the sperm and what qualities of the sperm are used to choose the best ones. So let's talk about sperm cells in general. What does a sperm cell look like, Victoria?
Okay. It looks like a little white tadpole.
Little tadpole.
Looks like a little tadpole. It just is like a little circle with a little flagella tail.
Yeah, so it has a head, a neck, and a tail.
It should. Not all do, and that's where my job comes in.
Yeah,
Not all do.
So let's say we have a couple come in and we don't really know what their problem is. We're going to examine the woman and check her out and whatnot. And evaluating a guy involves a semen analysis.
Yes.
And if a guy can produce a semen specimen, we can then analyze it in the lab. Now, I'm going to go right into what can be embarrassing for guys, Victoria. So let's take the embarrassment right off the table. Guys come into our office or any fertility clinic and have to make a semen specimen.
Yes.
That means they need to be comfortable doing what?
Ejaculating.
Ejaculating on command.
Yes.
And for some guys, it's no big deal. Boom, they're in and out 5 minutes, right? Some guys, it's a big deal. They're ashamed.
No, getting an
embarrassed.
erection in a place that's not your home is strange.
It's strange, isn't it?
I don't know it personally, but I imagine it would be very strange.
Yeah. So some guys, and sometimes they come from a religious background or a cultural background where it is frowned upon.
Yes, I've had men that came in there and did not know the terms for masturbation.
Right.
They did not know because in their culture, it's not discussed. It's not allowed outside of marriage or outside reproductive.
Yeah, outside of reproduction.
Yeah, reproduction.
So there's some challenges just in collecting a semen specimen sometimes, isn't there?
Yeah, for sure.
Now, in my clinic, I don't care how a guy collects. You know, we'll have the guy's wife come in, girlfriend, whatever. But where I trained, we had a lot of Orthodox Jews. And the only way they could collect was with a condom that had a pinhole in it. So they were having sexual relations, and it had the potential of creating a baby. Just so happens a condom with a pinhole in it, not many sperm are going to get out. So we had these special condoms that were not spermicidal. I mean, if you buy a condom for contraception, they say spermicidal. They're covered in sperm-killing chemicals. Can't do that.
And I don't think a lot of people know that. I feel like it can be written all over the box. They still don't know. I've had a man bring in a specimen before in a used condom. And we're like, you're just going to have to do this again because you compromised your own sample.
Right. So we can't, so the sperm can be, they're tough in some ways, yet they're sensitive to spermicides and temperature fluctuations.
Yes.
If a guy's going to collect at home, because let's say he's more comfortable at home, he can't bring it in getting cold in the middle of winter. Got to put it in a coat, bundle up, keep it warm.
Keep it as close to body temperature as possible.
So there you go. There's a hint, or there's a pointer right there. And in the summer, if it's baking hot, you shouldn't put it on the dashboard in the sun either.
Yeah, we want it to be as close to human conditions as possible. And that is hard doing that outside of a collection room, like 30 minutes away. That is hard, but you do have to deal with what you're comfortable with.
Right. So let's talk about how. So let's say most of the time we can get a semen specimen. And sometimes guys, that takes them a while to learn how to do it and say they can do it. We have a semen specimen. So it goes from the collection room into your lab.
Yes.
What then happens with a semen specimen?
I immediately put it in a warmer that's 37 degrees Celsius.
That's body temperature?
Yes, and we keep it there for 20 minutes for liquefaction to happen.
All right, so let's stop right there. Semen has enzymes in it that make it turn to liquid. And that's what happens in the body during intercourse so that the sperm can get out of the semen. So the first thing is it's kept warm until it liquefies. So we've got a liquefied specimen of semen in a cup here. It's coming into the lab. What does the andrology tech do next?
So after 20 minutes, I take it out of the warmer, and then I note the full volume. So I take the full volume in milliliters.
Okay.
And then we have a little semen analysis machine, or we can do it manually.
So let's go to old-fashioned, old school.
Manually. Okay.
Old school, before we had these computer-assisted analyses.
Yes.
What do we do?
So we would take the full volume first, because it's all part of a math equation. And sometimes the guys come out and they're like, I don't know if it was a full sample or a partial sample. And they think it doesn't matter. Or they're like, I don't even know what that means. It's just if you've made it all in the cup or not.
That's important, right?
Yes, because it's all part of a math equation to get your total number.
And some guys think there's not enough. And it's just fine.
Yes.
So what's the average volume of a semen specimen?
It's usually 1.5 mils to 5 mils.
To 5 mils.
Yes. Everyone thinks they need gallons and gallons and gallons, or they need to fill up the whole cup. And I'm like, no one could do that, or they would pass out. Like it would be insane. But
that reminds me of jokes. One of the jokes. I don't know how many jokes I'm going to tell during this session here, but one joke is the guy's in the room doing his thing, and it's an hour or two, and then finally, somebody knocks on the door and says, hey, Mr. Smith, what's taking you so long? And he goes, well, everything's going all right, but I can't seem to fill up the cup, So it's not.
I've had a man come out and say that to me. He's like, I couldn't fill up the whole cup.
I couldn't fill the cup.
No.
This is just fine.
Yes, this is fine.
This is just fine.
So, and then people think it's too small, and the average amount would be, on the smaller side, would be like the size of like a good sized blueberry.
A blueberry, yeah.
Yeah.
Yeah, just about over a milliliter.
Yeah.
Yeah, and if a guy has high density, that's enough. If there's a lot of sperm in there.
I think about everyone thinks they need huge volume. I think of it as like sweet tea. It's not how much tea you have, it's how much sugar's in the tea.
Gotcha.
Do you know what I mean? It's about
so
the
if
concentration.
It's really sweet, it's a concentration.
Yes.
And if it's really sweet, there's plenty of sugar in there.
Yes. Sugar being sperm. You know what I mean?
Yeah, absolutely.
Similar thing.
So it's liquefied and homogenized. So now it's the same concentration everywhere.
Yes. Yeah. Homogenized. So the same. So it's all It's all the same.
Okay.
And then we take the full volume again of what we have, because it's part of the math equation. And then we take a representative sample. That's a fixed number. We take a representative sample.
And that's with a little pipette. You take a little sample out of it.
And I put it under the microscope.
Into a counting chamber.
Yes. It's a glass counting chamber called a Mackler. That's the brand.
Yeah.
But then it's like a battleship grid on it.
Yeah, it's a grid.
Yes, just like battleship, like A4.
Yeah.
It's just like that. So we take a representative sample of that, and we count that grid, and it's in rows of 10. And so then we just go through and we count how many are modal with this little old school clicker.
You click the number moving
click.
And not moving.
Yes,
and we know the volume. And in that volume, in that Mackler, in that grid, it's a uniform thickness.
Yes.
So there's a precise volume. So now you're counting the number of sperm in a known volume.
Yes, we try to keep everything known so that the only variable is the specimen.
Okay.
Do you know what I mean?
Yeah, so it's controlled.
So they're the only,
you've got controlled
they're the only
volume,
variable.
Controlled time.
Yeah.
Controlled grid.
So then we do that, and then we, through Excel formulas, we get how many, the percent modal versus how many total for that concentration.
Okay, so the total sperm, living and dead.
Yes.
And then we want to know the percentage of them that are swimming around.
So that's the percent motility.
Okay.
And then you take the concentration times the motility times the full volume, and you get your total modal sperm, which is how many that are actually going to do something or have the potential to do something.
The potential to do something, yeah.
Yes.
So a typical semen analysis has the volume, it has the concentration. They call it the sperm count, but it's really the concentration, the percentage of them that are swimming. And then there's one more aspect of the sperm, and that's their shape.
Yes.
What's that called?
The morphology.
Morphology, which is Greek for shape. Now, that's where things can get real tricky. And I think you were just at a conference where they were talking about the controversies in the shape of sperm.
Yes.
So how do you determine if a sperm has a normal shape?
So there's strict morphology, and it's just been getting stricter and stricter throughout time. It used to be 30%. If you had 100 sperm and 30 of them were normal, we would say you have okay sperm. Okay? And now we're to the point where it's 4%. So if you had 100 sperm and 4 were normal, it'd be like, it's okay.
And going from 30% down to 4% isn't necessarily a decline, although we could talk separately about our sperm declining in the modern world and all that kind of stuff. But let's just assume right now that it's staying fairly constant enough for this discussion. Then the reason we've gone from 30% to 4% is because we're getting stricter, right?
Yes.
We want a perfect sperm head,
want
a perfect
the star
sperm tip, the star, the absolute best looking sperm. Now, do you have a picture there of sperm?
Yes.
And here is something that you actually were given at a conference recently. And sometimes these are tests. And will be tested. In fact, we have standards because how our lab gets certified is they'll send us standard proficiency testing. And you don't know how many are in there. And you have to get this unknown sample and put it in your macular counter or in our automatic counter and count it, come up with a number. And we send that back to the certifying lab, and they will tell us if we're getting pretty close to what they expect.
Recently, we were right on par.
We were right on.
Yes.
Yeah, so that's a whole nother world is a lab certification and all the stuff we do to stay certified and inspected and accredited.
So we do our morphology through the WHO, the World Health Organization, their criteria.
And what are those?
That's the 4%. But at the conference I was at recently, she thinks strict is too strict. And we should have a borderline, not just normal and abnormal, yes or no. We shouldn't do that. We should be more critical and observant and have an in-between called, what did she call it? I'm sorry. Called borderline.
Borderline.
Yeah, called borderline.
Yeah, because borderline sperm can probably in nature are contributing to the fertilization of the egg.
She said in one of the studies during her talk that the abnormal sperm, the borderline sperm, were found in cervical mucus. So they're obviously getting to the point where they can do their job.
They're getting somewhere.
They're just a little ugly.
Right.
Or abnormal looking. But they can still do their job, we think.
Right. We don't actually know which sperm gets in an egg in a natural conception.
Yes.
We just know that conception occurred. In fact, it's a somewhat hot topic is, if 4% is normal, how bad is 3%, in fact, does that make any difference? Or what if it's only 2% normal or 1% normal? So people have looked at this. An abnormal shape is called teratospermia. Terato is Greek for monster or abnormally shaped. And it turns out that 3% may not be very different from 4%. And in fact,
no, and I think to the layperson, that sounds crazy. Only 4% were normal.
Right.
But if you have 1 million sperm and 4% are normal, that's 40,000. That's a lot.
That's a lot.
That's a lot.
Exactly.
But it just sounds so small because of how large our count is.
Right.
Yes.
Right. We have a lot of guys who come in who've got kind of low counts. And sometimes they're severely low. Sometimes guys have none. And that's a whole another world. We may get to that, how we get sperm. If there's no sperm in the semen, but there's some sperm in the testicle, those can be found and retrieved
in different ways.
With the urologist, anesthesia, biopsies. It's called testicular sperm extraction. So if there's some sperm in there, we can get to it. But let's keep this part of the conversation right now is what do we do with semen that has sperm in it? So once we determine the guy has enough sperm to establish a pregnancy with some help, we can help couples where the guy has low to middling sperm but enough for us to give a boost to and get on target. So once we've done the semen analysis and we've determined a guy has enough sperm to work with, then the couple will come in for treatment. And most of the time we'll do something called insemination or intrauterine insemination. So how do you prepare a sperm sample for intrauterine insemination? Because let me just tell people that if you put semen in the uterus, it hurts. It does not belong up there because there's lots of chemicals in semen that can cause contractions. The most famous chemical in there is called prostaglandin, and that's what you give to make a uterus contract, in fact. So how do you make, or how do you prepare a semen specimen so we can put these sperm way up inside the uterus and give them a boost into the tubes?
Okay, so with an insemination or an IUI, intrauterine insemination, I always tell the man, your job's the same, mine's the only one that changed. So they go in there, produce their sample, it comes out, and I put it in the warmer again for 20 minutes. That's kind of standard again across all our procedures that I personally do.
Has to liquefy. That has to happen
has to
first.
liquefy, or it's just the basis of it. So once it's liquefied, then I take it out and we do the full volume and we get a count just like a semen analysis. See what he has going on to begin with.
Okay.
So we have a basis. So we can see how well we do improve or what are we doing, you know?
Do we have enough to work with?
Yeah. So we do an initial count and then I immediately concentrate it down.
How do you do that?
With a centrifuge.
That's a thing that
Just
spins
it
around.
around really fast merry-go-round.
Well, you go to 300 G or 500 G. It's many times the force of gravity.
Fast. Yeah, it's
pretty
pretty
fast.
fast. Don't put your finger in there and get chopped off.
Yeah, so you put the tube in there. Now, do you just spin the raw semen or do you mix it with
No, I spin
stuff?
the raw semen and then you get it balanced in the centrifuge and then you spin it for 5 minutes and then that just brings all the sperm down to the bottom because it's more dense than the seminal fluid.
Okay.
Yeah, so the seminal fluid is the fluid that the sperm is suspended in.
And that has the prostaglandins, white blood cells, all these chemicals and stuff. So you pellet. It's called making a pellet.
I make a pellet at the bottom.
These are special test tubes. They have a kind of a cone at the bottom.
Yeah, they're conical tubes.
They're conical tubes, so you make a pellet. So you spin the liquefied semen, you get a pellet.
Yes, and then I sorry, I can't think of the word.
The supernatant, you withdraw the supernatant, or how do you get that?
I take it down.
You take it down.
Yes.
So you take essentially pour that fluid off, or
I take it off. So I take the fluid off with a pipette, and I take it down to 1/2 ml. So we have a perfect little pellet at the bottom.
All right. So the pellet, now we've gotten rid of most of what's called the seminal plasma.
Yes.
All right. So then what do you do?
And so then I wash it. So we have a chemical wash, and that gets all the prostaglandin off. I call it the man gunk.
The man gunk. Let's get rid of it.
Yeah, I get rid of the man gunk.
That does not belong in the uterus.
So I put that in, and then we wash that for another 5 minutes, and then we.
And do you spin it again?
Yes. So then we spin it again, and then we put it on a gradient, which is think of like a chemical mesh.
Okay.
A chemical mesh, and so. We put it on a chemical mesh, and then only the modal will come through the mesh. And the non-modal will hopefully everybody is different. This is why we also do trial preps to see how will it perform, because everyone does perform different.
Okay.
Not everyone, but every sperm can perform different.
Yeah, and some sperm, you may have good numbers going in, but you don't have many very good numbers coming through.
They don't clean up well.
They don't clean up well.
Yeah, that's what we call that.
Right.
And so then we put it on this chemical mesh, basically. We call it a gradient. And then we take the supernat off. So we withdraw it down to the little pellet again to about 0.5 mils.
Okay.
And then I resuspend that, make it all homogeneous and uniform. And then I take a little sample, see how well we did, and do another count.
And see how many come through.
Yes. And then I take that and I load up the syringe and I put it back in the warmer.
And that is the fluid we can actually put inside the uterus.
Yes.
And when we do that with a long little catheter, used to be called a Tomcat, that was one of the first names of them. And then a nurse or a doctor can then take these washed, concentrated sperm and put them way up inside the uterus, directed towards the fallopian tubes.
Mm-hmm. I think the catheter looks like a little hummingbird beak.
Little hummingbird beak. There you go. I like that. I like that analogy. So we can take a guy who has low to midland sperm and would be very inefficient and establish a pregnancy through intercourse, But by concentrating the good sperm, cleaning them up, that also turns them on. It capacitates the sperm so they start swimming real fast. And now we can take a guy who has otherwise pretty low numbers, and if we can get 3 to 5 million in that final specimen or more, then we can have a pretty good pregnancy rate, can't we?
Yeah. Yeah.
And they're virtually almost zero risk of infection or problems. It's a painless procedure. So with your technology and your training and the stuff that you can do in the lab, you can treat a lot of male factor problems.
Yeah, you can treat a lot. Yeah, you can treat a lot of them.
So we can get out of a lot of problems. If a guy can't get it up on command, but he can make a specimen, his numbers are low. We sometimes have guys with spinal cord injuries for whatever reason they can't produce or whatnot, and those washed sperm can establish pregnancy. So that's fantastic. Now,
can I boast for 1 second?
Oh, please boast. I want to hear all the wonderful things you do.
Since I've started at Missouri Fertility, I have 112 positive betas from IUIs that I prepped alone.
112 positive pregnancy tests. Betas are shorthand for HCG, the pregnancy hormone. 112.
Yes.
That's not 112 babies. There are some miscarriages and some mishaps, but that's a good start. And we can say that the majority of those do develop into babies.
Which I've met.
And you've met some of your babies.
Yes, it's so cool.
Are any of them named Victoria
There is one named Victoria.
Yay!
And she's also a Leo.
A Leo.
And I love it. I love it.
Yeah, I joke around, and half joke to tell people they should name their kids Gilbert. And I have 2 kids named after me.
Isn't one a girl?
One's a girl. Her name is Jilly. And my best friend named his girl Jilly. And I will forever be touched and heartwarmed by the gesture.
I don't think this baby was named after me, but I can say it is.
It's a Victoria.
Yeah. Yeah.
I think you can take a claim on that.
Yeah.
Now, sometimes guys, when they ejaculate, the sperm doesn't come out. It goes backwards. So when do we see that?
It's in retrograde ejaculation.
Yeah.
And that can either be from trauma to that area. It could be from that.
Sometimes a surgery.
Or a surgery.
Guys had a surgery.
It could be from like diabetes.
Diabetes. That's what I wanted to get to.
Yes, it can be from diabetes.
Diabetes. High blood sugars over time will damage the nerves that control. There's 2. It's kind of simplified, but there's 2 sphincter muscles. And if the internal sphincter muscle is weak or is open, sperm come from what's called the vas or the ejaculatory ducts, reach the urinary system and go backwards into the urine. So the guy has an orgasm, but there's no sperm coming out of his body.
I like to compare it to when you drink water and it goes down the wrong tube.
Goes down the wrong tube.
Yes, so it goes down the wrong tube, and then they do ejaculate. They have the sensation sometimes.
Right.
Sometimes they don't. It's called a dry ejaculation.
Okay.
And then it does go back into their bladder sometimes.
So now it's in their urine and their bladder.
But there are some people who can do both. It comes out in an ejaculation and their bladder.
And so there's kind of
it's a whole spectrum.
It's a whole spectrum.
It's a whole spectrum.
So it's your job as an andrology tech to be able to get the sperm wherever it is.
Yeah.
So we can clean it up, concentrate it, and get it on target. So let's say we know a guy has had diabetes. He's got this retrograde problem. What do we do for a guy like that who has sperm in his urine?
So first, we need to prepare days before. So it's not a spur-of-the-moment thing all the time. It can't be. For it to be optimized and successful.
So you need to know,
who's coming in the door.
Who's coming in the door.
Yeah.
So you have time, what's called bench time. You need to be ready for this.
Yes. Well, also, he needs to prepare by taking a bicarbonate drink.
Baking soda.
Yes, he needs to take a bicarbonate drink, and I think it's Mucinex or Sudafed for 4 days before.
And the Sudafed, can help the muscular
The
contractions,
sphincters, yes.
the sphincters be stronger. So urine can be somewhat toxic to the sperm if it's too acidic.
Yes.
So the guy starts preparing beforehand by drinking baking soda to make his urine more basic. And I think he does that the morning of or a few hours before this. So he does his thing. Now he has a bladder full of urine and sperm. What do you do now in the lab to get those sperm?
So after we have our sample, so we're going to tell him, first of all, to get the sample, we're going to tell him as soon as you're done and you have felt the ejaculation sensation,
right,
then immediately try to get something in the cup. If there's not anything in the cup, that's fine. We give them 2 cups.
Oh, there's
and
2 cups, right?
Yes. And then the second cup, we say urinate immediately after.
And that's a bigger cup.
It's the same cup.
Really?
Yes. Everyone thinks they need to fill up all the cups. You mostly only fill that cup up if it's urine.
So that cup. So now you have a cup of urine that hopefully has sperm in it.
Hopefully. It can be hit or miss.
Hit or miss.
We've had some people, we don't know if they followed directions correctly or if it was just a bad day, but we can have some days where there's nothing in there after doing all the processing.
All right, but let's say it's a good day.
Yes.
There's sperm in the urine. What do you do now?
So immediately, we don't put it in the warmer because we want to get it out of the urine and the uric acid immediately.
Quickly as possible.
Quickly as possible.
Okay.
So we immediately get the full volume. And then we immediately divide it up and we centrifuge it.
So now you've got a lot of urine. So you're spinning a bunch of tubes.
We have 2 centrifuges going because it is a high volume because it is urine.
You're spinning a lot of tubes.
So normally it's like 50 mils instead of what I usually deal with is like 5.
5, right, most.
Yeah, so it's a lot more. So we get it all spun down and then we get them all to uniform pellets and then we combine all the pellets into one.
So now the sperm is concentrated in one place
tube.
and out of the urine for the most part.
Out of the urine for the most part. And so we wash it 1 or 2 times depending on the specimen. And so we centrifuge that again for 5 minutes or longer depending on the case. And then we treat it like a normal insemination. If we do have sperm.
So if we can get 3 to 5 million or more sperm from what's called a retrograde prep, we've overcome the male factor. And
we've had a success before.
Oh, we have successes. Absolutely.
Yeah.
Absolutely. So
it is a more difficult case, and I don't think the success rates are beautiful.
Yeah, they're not fantastic.
They're not fantastic, but it is possible.
And we can get a pregnancy from insemination rather than the super high-tech and expensive process of in vitro fertilization. So maybe we should move on to that. Now, let's say a guy is leaving town for many months. He's going off to war. We have guys who are deployed overseas for long periods of time. And if they have pretty good sperm numbers, what can we do about that?
For an insemination or for any kind of treatment?
Well, he's got good sperm numbers, but his wife's, they want to get pregnant. He's leaving the country. And so we're going to be ovulating his wife while he's gone.
Okay.
So we can freeze his sperm. What I'm getting to is
we can freeze his sperm and freeze time.
And freeze time. So it's called cryopreservation. Cryo means cold. So how do you, first, and let's say this, first of all, he has to have fairly good sperm numbers to cryo for future inseminations. But it can be done. So it's a guy's young, healthy soldier, good sperm numbers. How do you freeze time, Victoria?
So we have him do his thing. He comes, we get the specimen, and then we immediately put it in the warmer, 20 minutes standard. And then when it comes out, we get the full volume, do a count, just like every other thing. And then we spin it down to 0.5 mils again. We love that number.
Right.
And then we suspend it and we freeze it in a 1-to-1 ratio with our cryo media. Our special media.
A cryoprotectant.
Yes.
Now it used to be yellow. Because
now it's a pretty pink.
Now it's a pretty pink. It used to be yellow because one of the ingredients was egg yolk.
Really?
Yeah, egg yolk has this protein. It has lecithin. It has these oils and phospholipids and all this stuff. And it was one of the ingredients in the cryoprotectant. So old frozen, I would see, this
That's
is where my
interesting.
age. Yes, so cryoprotectant used to have egg yolk in it, so it came out yellow.
So did fresco paintings, like for cathedrals.
Right, yeah, that's right.
Art and
fresco.
science.
That's right.
It's crazy.
That's right.
Yeah.
I think Michelangelo's Last Supper was painted
Yes.
in those. That's why it kind of crumbled. It wasn't as durable
Put it in a
as
hot sun, you get an omelet.
right.
Yeah, yeah.
So nowadays you have a cryoprotectant. You just buy it off the shelf. Comes ready to use. So you mix it 1-to-1 with a cryoprotectant.
Yes. And we have to do it dropwise every 10 seconds. So
you
it
have to
takes a
add
minute.
it.
You're just
So you can't just mix it. You
Nope.
have to be done properly.
because you
There's
don't
a
want to
technique.
shock the sperm. You can overwhelm them, and then they're like, oh. That's in my head what I think they do.
So we don't shock. So you
No.
don't shock the sperm.
Yes, and even with freezing, it's a slow process. It takes 2 hours.
And you have a machine that does that.
No, we do it.
How do you? So you've got
I have the pellet,
sperm. You got the
resuspended.
pellet. Okay.
And then I do 1-to-1 ratio dropwise of the cryoprotectant. And then you leave it alone for 3 minutes on the counter to settle and get to ambient temperature really fast. You just leave
Stand back.
it. Yes.
Okay.
And then you put it in our fridge that's like 2 to 4 degrees Celsius
Okay.
for 20 minutes.
So you pre-chill it. So now
Yes.
you're starting to chill it.
And then we have our tanks where we store the sperm. And that's with liquid nitrogen.
Liquid, and that's like minus 190 something.
Very,
right?
very, very cold.
Ultra cold.
Instant frostbite.
Yes.
Yes. So after the 20 minutes in the fridge, then we dangle it just in the little cold air. We dangle it in the cold air above the tank where the meniscus is.
Okay, the
And then-
vapor.
Yes, we just dangle it in the vapor for 30 minutes, and then it slowly freezes.
Do you just hang it down there and put it on a little hook and let it
Yeah.
and walk away again?
Yeah, for
So now
30
you walk
minutes.
away. And it freezes there, right? Because that's really cold in the
Yes.
vapor, right? All right, so you've taken it from chilled to frozen in
Yeah.
the vapor.
Yeah, it's like a step ladder down of temperatures.
And then what do you do?
And then once it's at 30 minutes, then I find a place in the tank where it can live for a little bit, and I put it in the tank.
And
And
what
that's
kind
it.
of, is it in a tube or a vial?
It's
or
in a little vial. That's what we freeze it in.
a special vial.
Yeah, it's called a cryo vial, and we use special cryo pens, everything special cryo.
So his name, his date of birth, identifying information. Because people ask us all the time, how do I know this is my sperm, right?
Because I don't mess up.
Because you don't mess up.
No,
we have
we
a chain
work
of
on
custody.
one specimen at a time.
Uh-huh.
Everything's double witnessed. Everyone makes sure that it's the right specimen for the right person for the right procedure.
So if we do it right, that's what's called a zero event. There will be zero mix-ups because we take our time and
One specimen at a time.
one at a time, and it's witness and all that stuff. So, all right. So if a guy's got good numbers, he's out of town for a while, we can cryo his specimens, and then when his wife is ovulating in his absence, we can thaw it out, do an insemination, and get pretty good pregnancy rates
Yeah,
while
we
he's
just thaw it out. It's basically, we could wash it or we can not wash it before or after freezing. So we could thaw it, put in a wash just like an insemination, spin it for 5 minutes, put it in the hummingbird beak catheter, and perform it like a normal IUI.
and
In
we
the
count it. We
absence-
know there's enough
Yes.
there. We get a count. We can be assured that our numbers are good. If they're good, and if the numbers are poor, you can thaw out another one.
Yes, you can combine them.
Keep combining them
Yes.
until we get the 3 to 5
We
million.
can put 20 together and try to get the number. We can have one and get the number. Every specimen's different.
So that requires some diligence on your part and attention to detail, and making sure we have enough to work with and be prepared for this. Fantastic. So a number of things can affect a guy's sperm count, his numbers, his morphology, his motility, and his fertility in general. And we've already mentioned how diabetes can cause problems. Are there any other issues that might be in a guy's control that he can perhaps, or at least get some suspicion he might have a sperm problem, or something that would warrant treatment, or maybe some lifestyle changes?
I think a lot of men don't think about it until they have to, until it's brought to their attention, not them seeking it out.
Right.
But there are so many environmental factors. Like the age-old joke is like, Mountain Dew kills your sperm. Don't drink Mountain Dew. Like, it doesn't, but there is environmental factors. It's not Mountain Dew, but I'm sure if you drank 8 gallons a day,
Right.
probably
If
would.
you lived on Mountain Dew.
Yes. But everything in moderation won't.
Is a good rule of thumb.
Yes, it is a good rule of thumb, but there are certain things that are very harmful to sperm production, just like smoking, weed, or tobacco, cigarettes.
And you were at a conference recently where one of the researchers came down hard on smoking weed, right?
Yes, he was not a fan.
Not a fan.
And it can affect it. There's been studies, and they are slower with motility. And they can be jerky, or if you're doing harder drugs like heroin or anything, they can be more jerky and fast and spazzy.
Yeah. I wonder if there's any data on edibles, because there isn't a smoke toxin component to that, but there's still the chemicals and the drugs in there. I bet you over time they'll figure that out.
And all the byproduct chemicals and all the things that congeal it together. And
I remember when vaping got popular, I don't know, 5-10 years ago, and it seemed, oh my goodness, this will be safer because there's none of this smoke and the tars and smoke. Turns out these little droplets are horrible on your lungs. In fact, vaping may not be safer. In fact, might be more harmful in some ways.
It's a lot of the toxic vitamin E oil that they put in the suspension, along with other carcinogens, obviously. But a lot of it's the vitamin E oil.
Yeah, those particles of tocopherol, they get oxidized or whatnot and can really chew up your lungs.
Yeah, but no one thinks about that. They just suck on it like a pacifier.
Right.
No
they
one
think it's safer.
about it. Yeah, because it's not demonized as much as smoking cigarettes are.
Right. Now, some people think that they, if they take a lot of vitamins, they can really help their sperm counts and whatnot. So what's the latest on that? I think you got some information just recently on that as well.
Okay. Well, personally, I think vitamins, you're making your pee expensive. If you're eating a proper diet, you are peeing them out, mostly.
Mostly, yeah.
Yes. And I've had professors in college say the same thing. Unless you are deficient in something, you're just peeing it out. You're making yourself feel good personally that you're maybe doing something.
Right.
But to a point, it can be counterproductive.
Yeah, that was interesting. Tell me more about that.
So there has been studies saying vitamin D or vitamin C can reduce oxidative stress, which is like DNA damage within the sperm.
All right, so oxidative stress is bad.
Yes, we don't like that.
We don't like
Don't like it.
From reactive oxygen species, ROSs.
But people think vitamin C, there has been studies, vitamin C. So they hit it with a hammer. And
they take massive doses.
Yeah, they do vitamin C, or what is that called? Emergency. They do emergency.
Right.
And that's 1,000 milligrams of vitamin C.
Okay.
And when I went to this conference, he said all you need is 100 milligrams. So people are doing 10 times what's needed. And it can be counterproductive. It just can reintroduce more.
Excuse me.
It can reintroduce more free radicals and oxidative stress, and you're just putting your body through more for what?
So there might be some data to suggest that high doses of vitamin C can be counterproductive.
Yes, as well as zinc.
And zinc can be counterproductive.
They say you only need about 10 milligrams, but everyone goes overboard. And then your body just has to work harder to process this and get it out of his system.
It may not have the desired effect. Very interesting.
Well, and a lot of the vitamin C pills you can buy on the market, they're like 200 milligrams minimum. So it's already double what is needed to be effective.
Right. I used to be a big proponent of high-dose vitamin C. There was a scientist called Linus Pauling who had some real good ideas. And in fact, I mean, people still talk about it as a treatment for some cancers in special situations. And people can debate that, but from what you're telling me, experts in the field right now feel that you can overdose vitamin C. You can overdose zinc.
Yes.
So you can't make up for drinking heavily, intoxifying yourself with alcohol or vaping or smoking too much weed or all that kind of stuff. You can't necessarily fix it, so you got to go back to being healthy if that's your problem, right? Now, sometimes guys get abnormal veins in their scrotum. It's called a varicocele, which can cause, I believe, what are called stress patterns on the sperm, where they don't swim as well, and there's more abnormal forms.
And there can be less.
Tell me more about what you know about that.
The tubes, the vas deferens, or the epididymis can all be pressurized by these enlarged veins that are carrying the oxygenated blood from the scrotum back to the body.
Okay.
And so those veins can get chunky and just big and can press on things that that mess up the transport of the sperm out of the penis.
So the plumbing, let me explain that. In the testes are seminiferous tubules, these little tubes where sperm are produced. It's a big web of them. But they all come together eventually into a common, it's like a tree trunk, right?
Yes.
They come together at the trunk. And then just outside the testes, there's something called epididymis, another kind of curly Q piece of plumbing where the sperm do mature a little more. And then those epididymi come together into what's called the vas deferens, or the ejaculatory ducts. And then that makes it all the way around through the groin, up and around, over this, under that, and blah, blah, blah. And then eventually join in the prostate gland, and then mix it. So it is really complicated.
Yes.
So a big ball of veins that are pressing on things, that are heating up things.
Yeah, they heat up things, which can also overheat the sperm and kill them off, can make oxidative stress higher because your body temperature is higher.
Yeah,
and you usually want your scrotum to be about 2 degrees lower than body heat.
I've heard maybe up to 6, but certainly cooler. I mean, in all mammals, the testes are outside of the body to be cooler, be cooler.
And evolution has a purpose. It's for a reason.
Yeah. Speaking of evolution, sperm cells go way back. I was reading the first sperm cells began to evolve with animals 600 million years ago.
That's insane.
Isn't that amazing? Yeah, reproduction is just an amazing process. You've got our genetics. A guy and a gal both have to split their genetics in half into an egg and a sperm so it can reunite to make a whole again. What an incredible process. Easily screwed up and messed up.
Oh, yes. All the time.
Yeah, so we've talked about how we can give sperm a boost, and guys with a low count can essentially be boosted up and made almost as fertile with insemination. But what do we do with guys with super low sperm counts? We can't get those 3 million sperm put together. What can you do
we're going to
there?
take our tool from before, the cryopreservation, and we're going to try to get as many of those as possible and just stack them on top of each other. And then when it's time, we're going to thaw them all. Usually time is egg retrieval or egg thaw if there's donor eggs. And we're doing IVF. So
your work as an andrology tech in the lab is very similar when we're doing in vitro fertilization. Now, in vitro means in the lab or in glass. So we can get eggs out of a woman, and we need to fertilize them. But instead of needing millions and millions of sperm, we're now doing it with special instruments, tiny little needles, and we're putting one sperm into each egg through this ICSI procedure. But our embryologist needs those sperm in the lab, even though he doesn't need a lot. He needs those good sperm. So
he needs a good population to pick through to find the star pupil.
The stars.
Yes, because why would we choose anything less if we have the option?
Right. And I know some people have claimed, some labs and clinics have claimed that with a super high powerful microscope, they can pick the best of the best of the best. Unfortunately, that's not been shown to be the case. Just what you do with the microscope and selecting what appears to be good-looking sperm is as good as
equivalent.
Equivalent. Yeah. So you can get these sperm, concentrate them, and even though it's a lot, it's enough to do in vitro fertilization usually. Yeah.
And when our embryologist is picking out the best sperm, there is a criteria we go through to find the best star pupils, and we can talk about that.
Please, so tell me, so how do we pick
a
good sperm, the best sperm to inject in the eggs for IVF?
Like ones there's a whole checklist, if we want to see, where's the camera?
Yeah.
A whole checklist.
So tell me about this checklist. I'm fascinated.
First, we like to see, is it a whole sperm? Because some sperm can just be the head. Some can just be the tail. They can get chopped off in production. They can get chopped off in ejaculation.
So they're fragile. They don't survive.
Somewhat. They're not as fragile as eggs. They have more plasticity, I think. I think. So first we see if it's a whole sperm. If it's not a whole sperm, we don't deal with it.
All right. So it's got to be the whole sperm, the head, the neck, and the tail.
Yes. Okay. Yes. And then we see if there's any cytoplasmic droplets. So if there's any little cytoplasm just sitting on there. Because it is heavy, it will impact the way it moves.
So a cytoplasmic droplet, it's like this little thing that kind of sticks off the sperm. It's a little outpouching or something.
Yes.
So it's not this perfect compact head. There's these little things glommed onto it.
Yeah, it gets like a little globby. And that can, I think the main thing with most of biology is form yields function. If it looks crazy, it's going to act crazy. Because that's how the mechanics are and that's how it's built. Same with protein, same down to everything. Everything. I think it all connects.
It's a similar idea. That makes a lot of sense.
Yes. So and then we see if there's any tail defects. Sometimes a tail can be really thick. And that thing's going to be too heavy to whip around and move successfully as much as someone with a skinnier tail.
A normal tail.
It around.
A normal tail. Because these things go around and around. People think they go like this. They actually go around and around.
Like a little helicopter.
It's a little helicopter, and it makes a spiral, and that's what propels the sperm through fluid.
So we have to see if their tails can be pinned straight, and that means it's not going to wave right.
A rigid.
Yes, it can be a rigid, and usually we think those sperm could be dead and not even motile. Who knows? There is hairpin tails where it looks like a little bobby pin.
A bobby pin.
And those ones will not swim right because it's just, there's some that are crooked enough they move like a little chicken wing. And those they could get there, but who knows?
But that's not good.
No, we want the star runner, Star Trek star. You know?
All right. So there's tail defects.
Yes.
And I think they can be bent or kink tails.
They can be bent and kinked, but if they move, they move. So we don't need a perfect, like, beautiful wave. It just has to move forward in some direction.
Okay. So so you have to be
progressive. With your motility.
Okay. So there's a tail problem. Okay.
Yes.
So okay, go on.
Okay. And then we look if there's a mid piece, the neck.
Okay.
And so we like to see it as a balloon, kind of. Like where it comes to like a snow cone,
Okay.
We like to see it come to a snow cone head.
The neck part or the bottom of the head?
The bottom of the head to the neck.
To the neck. Want to make it like a
snow
cone.
cone.
A snow cone.
And then we don't want it to be too thick. We don't want it to be off to the side. Sometimes the neck can attach on the side. And that won't work because it's going to... You have to think of the fluidics of it. It's not going to...
And that suggests a possible problem in it there.
Yes, and with like DNA fragmentation.
Yeah, so it has to be directly below in the snow cone look.
Yes,
this ice
and
cream
you don't
cone
want
look.
the neck to be too chunky, too fat. You just want it to be...
So this, I'm going to say this, I'm going to emphasize this, and I do this almost every specialist here, and no matter what field, this is where experience comes in. This is where you want to go to somebody that does this all the time.
Yeah, because they've seen everything. Or close to everything.
Right. So you've seen bazillions of sperm, and when you look at a sperm, you can really tell a lot of the time. So now continue with your criteria.
Okay. So then after the mid piece, then we're like, is there two heads? There can be two heads.
Really?
There can be three. I've never seen 3 heads, but there could be 3 heads. There can be 2 heads. So with that, we don't want that because obviously there's a problem.
It's
going to swim wonky. It's not going to do the job, and if it does, we might know.
So sperm can have 2 heads. Can a sperm have 2 tails?
Yes, it can. We call those dimorphic sperm.
Dimorphic sperm.
Yes, 2.
So you even have a number, have a descriptor for that. Continue on. This is fascinating.
And then we look, is the head too small or too large? Because it could just be a huge old bobblehead. And who knows if that'll work? Why is it big? It could have chromosome issues. It could have DNA issues.
It has to be just right.
Or we don't want too small. We call the 2 small ones, we call them pinheads.
So pinhead's no good either.
No.
There's no DNA. There's not enough DNA in
and
there.
half the time, those just look like little swimming tails.
So it's like a naked tail with a pinhead.
Yes. And those ones usually whip around a lot.
Good. All right.
Yes. And then we say, is the acrosome missing or not?
What is the acrosome, please?
Is in the head of the sperm.
Okay.
So we have the head. We have the snow cone.
All right.
And it's the very top of the snow cone.
The tip up there.
Where all the DNA is compacted, the paternal DNA.
Well, no, I think the DNA is just below the acrosome. The acrosome has
the enzymes.
Has the digestive enzymes.
So
it's the warhead that's going to help eat through the wall of the egg in a normal situation.
Yes, in a normal.
So tell me about the acrosome. You don't know. All right. Well, I know it has digestive enzymes.
Yes.
I don't know that much about it either. But the shape isn't there a normal size to it and
Usually
whatnot?
for the acrosome, we want it to not be too small because then we think something's missing. It doesn't have the enzymes. It's not packaged the way it's supposed to be.
Gotcha.
But in our talk for the conference, she said it can never be too big, which could be controversial.
So bigger is better when it comes to acrosome.
Maybe not bigger is better, but it's not worse.
It's not a problem.
Yeah.
If you see, let's say, a generous acrosome, that could be a good sperm.
Mm-hmm.
Okay.
Yes. And that can be done with like fixating a sperm. We can see how big the acrosome is because it doesn't take up dye as much. So you can visualize it.
You can visualize now. So you can take a sample of the sperm. Essentially, you kill them. If you stick them to the slide and you stain them, and you can see like how many of these sperm in this population have big acrosomes, small acrosomes, all that stuff. But those aren't the sperm we're actually using.
No, those ones are sacrificial lambs.
They're sacrificial lambs.
Yes.
Gotcha.
Just to see what's going on. Take temperature of the room, you know?
Yeah.
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 Okay. So then after the acrosome, then we say, is the head elongated? Is it a long tubule thing? Because I don't know, but we just don't want it to be elongated. We want the ratio to be 2 to 1. So as fat as it is.
So you want twice as long as wide.
Fat. Yes.
So 2 to 1 is the normal ratio.
2 to 1 is the normal ratio.
Ah.
So we look for that.
Okay.
So we look for that. And then afterwards we said, is the head grossly dimorphic? So does the head have a lot of bumps? That's a fancy way of saying, does it have a lot of bumps? Does it have a lot of indents? Did it get a fender bender on the way here? Who knows, you know? Some of them could be little half moons. Some they could be squished. But we want ones that look like the perfect snow cone.
The perfect snow cone.
The perfect
round,
snow cone.
even, symmetrical.
Yes. Yes, symmetrical for sure.
Okay.
For sure. And then we look if there's vacuoles present. So if there's large cytoplasmic vacuoles.
Like these little voids, these little empty areas in the sperm head.
Yes, little voids. That's a good way to put it.
Voids, little round things, and they're called vacuoles. We see vacuoles in eggs too. We don't like vacuoles.
Yeah, we don't like them. We don't like large vacuoles. Small ones we can overlook because how perfect is perfect?
Right. So a few little
a few
vacuoles,
is fine.
no big deal.
Yes. And then now, everything we said before, it's abnormal. If it has those things, we say abnormal, we don't like it.
Okay.
Then at our talk, what we did talk about was borderline.
So this is a recent thought.
Yes.
That
a
maybe
recent discussion.
Yes, as people are bringing up,
about.
if it's not perfect, it might be good enough.
So what she was saying, should I get her name?
Yeah, let's give her credit.
Let's shout her out.
You were just at a conference.
Anna Marie Bort.
Say her name. What was her name again, please?
Anna Marie Bort gave a talk on sperm morphology at the Andrology convention in Denver. And her idea, maybe not her idea, but she gave a talk on maybe borderline sperm and not just having it be a strict criteria of yes and no. We don't like this or we do like this. That we should think more critically about it and we should have a middle ground. And the middle ground would still be technically abnormal, but it makes us think more critically about it.
And they might contribute if they were part of an insemination specimen. We're sending millions of sperm on their journey, on their mission, that they may contribute. They may help fertilize the egg.
She was talking with a recent study that she was part of that they did find borderline sperm in some cervical mucus. So it's obviously getting to the point where it could do its job.
Right.
And there's evidence of that. But do we know if it finishes its job?
We don't know.
We do not know.
But it might contribute. They might be helping get the best sperm into the egg.
So the ones we said could be borderline are called globular sperm. And they're just little circles.
Around.
The heads are little circles.
Globulars, no good. They don't have that 2 to 1 ratio.
No, but we still think they could. They could finish the job. But we don't like them that much.
We don't like them.
No. And then we try to see if it's just like a little bump out. The last thing is if there's a little bump out, if there's a little fender bender, maybe it's borderline.
But in order to get that perfect criteria right now, in that 4%, it's got to be normal in all those ways.
Yes.
Very interesting. So
it is very strict. And she was discussing maybe it should be critical morphology and not strict morphology.
Ah,
So it's an
interesting.
idea.
Yeah, so
It's an
this is
idea.
evolving. So the assessment of sperm shape is evolving. There's new thoughts coming in. But when our embryologist is in the IVF lab, we've concentrated the best looking sperm, the moving sperm, and then in our lab, his name is David. David is going to be taking the absolute best looking sperm and using them to inject them in the egg. So all of your work with all these potentially millions of sperm comes down to this handful of sperm or the one sperm per egg.
So to get there, we have to thaw them all. And then
In poor specimens with low numbers.
yes.
We have
With anybody for IVF. Most of the time. I mean, we can do a fresh collection, but to just take stress off the man, he doesn't have to perform the same day. His wife is getting an egg retrieval.
It's a very stressful day.
That'd be a lot on your brain. I don't know.
Yeah, right.
So we mostly cryopreserve before, just so it takes the stress off the man's brain. Maybe what if we get there and he can't perform that day?
Right, and the stress only makes it worse.
So we have backups, and if they do have poor numbers, then we'll have a lot of backups, and we'll thaw them all, and then I'll process them, and I'll double wash those. So I'll spin them again with the wash, and I'll do that twice. And then I layer it. Think of like a fancy bartender, okay? So I take the wash. Yes. So I take the wash, and I put a little bit of wash at the bottom of a test tube.
Okay.
And then I take the purified sperm that I make into the tiny little pellet again after all the centrifuging, and I layer it very carefully on top. And so it sits on top of each other like a fancy shot.
Okay.
Okay?
Well, yeah, the B-52 or whatever.
Yes.
Yeah.
So we layer it on top, and then I give it to our embryologist 3 hours before he's going to do ICSI inseminations.
Okay.
So we layer it like a fancy drink.
Yeah.
And so if we have our purified sperm pellet that we put through 2 things of wash, and then we have the 0.5 mils of the purified sperm, and then on top I take 0.5 mils, around 0.5 mils of the wash and layer it on top. Okay. And then that's 3 hours. That's done 3 hours before when our embryologist does ICSI. And then in those 3 hours, it goes in a warmer for optimal temperature. And then the sperm swim up. And then our embryologists skip. Yeah. And so they swim up, and then our embryologist skims the best ones off the top, and then he selects which ones he wants.
And those are the winners.
Yes.
Fantastic.
So it's a lot of collaboration when you think about it.
It's a lot of logistics. It's a lot of moving parts. In order to have an IVF lab function at the, in the state of the art, a lot of smart people doing a lot of technically difficult things sometimes. Fantastic. So, Victoria, can you think of any other things about the work you do in the andrology lab that people might find interesting? We've talked about how it can be challenging collecting, it can be challenging processing. We have challenges with low numbers. We have challenges with diabetes and other problems people might have. Do you do much work with actual what are called testicular biopsies? And let me explain to our folks, if the vas, if the duct coming out of the testis is blocked and they just aren't coming out, we work with a urologist, and we put a guy to sleep who can actually, the urologist can take little specimens of the testicle, and that's called a testicular sperm extraction. Are you involved in taking sperm out of those little biopsies?
Yes, I am.
So how do you do that? So instead of it swimming around, you now have a solid piece of tissue with these seminiferous tubules in which the sperm have actually, grown and been created. How do you get sperm out of a solid piece of tissue?
So we call it Tessie, just commonly around our lab.
All right, how do you do
we
it,
call it Tessie. So we work with the urologist. They put them to sleep. And then once they're asleep, then the urologist cuts open the testicle through the skin, through the epidermis.
The tunica, and it gets down to the actual testicle.
Yes, and then he cuts open a tiny portion of, everyone thinks it's crazy, you're chopping the whole thing in half.
It's just a little tiny piece.
Itty bitty. The guys are walking around, hey, what's up? Right after.
Right afterwards,
fine. Yes, you can go to work the next day.
Yeah.
And we open it up a little bit, make a micro
incision?
Micro incision. We make a micro incision.
Yeah.
And then our urologist, takes his little curved scissors, takes a couple chunks off, And it's
little
not
tiny
big
scissors.
chunks. It's itty bitty.
Tiny little pieces. And
Itty,
by
itty
the way,
bitty.
the urologist is named Clay Mecklin, and he has his own episode. We did a number of episodes ago.
Yeah.
Yeah, we've interviewed him on another podcast, and our viewers should feel free to go see his talk. So from this little biopsy, how do you get sperm out of that? Normally those are frozen now, right?
Yes.
So you look at them under the microscope, make sure there are some sperm in those pieces.
Yes. So immediately we go to our fancy microscope, the inverted microscope in the IVF lab that we use for eggs and ICSI and everything. And we see, is there sperm in this tissue? Because we'll see red blood cells, we'll see cellular debris, we'll just see tissue.
Right.
And so it's not a clear-cut picture. So we have to look through and see if there are any sperm, motile or immotile.
Okay.
And then the ones that are there are usually immature because they haven't left
They're
the
still in the
testicle.
tube. They're still developing in
so
the tubules.
they're immature, but some can be close to on their way to graduating. So those are the ones we like.
So right beforehand, they're still good enough to use for ICSI.
Yes.
You can fertilize an egg with those.
So we take those, and then when we see there is sperm, then we get a couple more samples, because if there's not, then maybe we'll go to the other testicle. We'll figure out where, if we have sperm, if we don't. And we can also do this for vasectomies, people who have had vasectomies and don't do reversals, or the reversal didn't work.
There. And so you can get this biopsy. So what do you do with this little piece of tissue?
So then
you
we
look
take
at
the
it, make sure there's sperm in there.
Yes.
How do you freeze it?
So first, when we're still in the lab, while the surgery is happening or the procedure is happening, we take curved scissors and we smush the tubules. You smush the tissue and try to process it out of the tubules and kind of mush it up.
So you mush it up. You kind of mush the sperm out of the tubules.
You kind of
free them up a little bit.
Yes. And then after that, then we put it in a tube. It's like a little grinder. And then we grind it up.
Grind it down.
Yes, to get the tissue just more free, because it is trapped in the tissue. So we're just trying to break up the tissue. And the sperm are so small, it doesn't hurt them. It's fine.
Right.
It's
the
fine.
grinder is a tube inside of a tube.
Yes, it's a conical
And there's a
tube.
tolerance, and there's just a small gap between the two. And that gap is bigger than a sperm. So the tissue gets ground, the sperm get liberated.
And so then I take it to my lab, and then I freeze it just like I would a cryo.
Same kind of cryo idea.
Yeah, we freeze it.
Same stuff. Mix it, chill it, vapor, plunge it, and then liquid nitrogen.
Because once we have our product, we can work with it similarly like we do before.
Amazing. So we can even work with small pieces of testicular tissue, and that's enough to do IVF with ICSI. Fascinating. So as long as you have some sperm in the body and they're genetically normal and they have all they need, and sometimes they have the normal morphology, that can be used with eggs to make good embryos. And those good embryos can turn into good pregnancies, and those can turn into beautiful little babies. And you get another notch on your belt.
Yes, another little notch on my belt.
Well, that's fascinating, Victoria. That was so interesting. I have learned so much from you. What a delightful discussion. I want to thank you for your time tonight, telling us all the things you can do as the sperm whisperer to help our patients achieve successful pregnancies. Well, what
thank
delightful
you for having me.
So nice to have you here, Victoria. Thank you so much.
You too. Thank you.